It is now 11 a.m., so we will get started. Thank you all for joining the Georgia Department of Public Health Strike and Support Office Hour. My name is Maya Labat, your host for today's event, and I will hand it off to Melody Brown from Alliant.
Thank you, Maya. And again, good morning, everyone, and thank you for joining today. We are happy to bring you another office hours with a lot of information. In fact, this was just changed as of this morning. So I want to thank Erica and Dr. Gar for making those quick changes for some updates that they found overnight almost. So next slide, please. Again, our presenters today will be Dr. Gar, who serves as a medical director for Alliant Health Solutions, as well as in a nursing home where she is active every day, working with residents in the nursing homes. And Erica, our infection prevention specialist with Alliant Health Solutions. So they will be bringing you the information to share today. And I have dropped the link in the chat box for the presentation slides today, which are also going to be posted on our website, and I'll drop it in again at least a couple of times so that you will have those if you want to use these for reference in your education for staff and everyone. This event is being recorded today, so if you have any technical issues, also please drop that in chat. Again, Dr. Gar, here is her bio, so you can have that. She is all over the place working and representing Alliant as well as Georgia Medical Directors Association and others in the state of Georgia and all over the place. Next slide. And Erica is one of our infection prevention specialists. I want to throw out here that if any time you have questions or have any needs in the state of Georgia, please let us know, and either myself or Erica will certainly try to help you with your infection prevention questions and issues. We want to thank our partners, the Georgia Department of Public Health, as well as the University of Georgia, for without them, we would not be able to be doing these office hours on a monthly basis. And at this time, I'm going to turn the presentation over to Dr. Gar. If you will give our objectives and then tell us all of the updates, Dr. Gar, that you and then Erica have. Thank you.
Absolutely. Thank you, Mel. So today we are going to talk about the big updates that have happened. So there are two areas where big updates have happened, right? One is the COVID-19 vaccine and the boosters and the up-to-date definitions, etc. And then the other big area is the infection prevention and control recommendation changes that happened from CDC. Of course, with that, we got a new QSO, from CMS, and that is also going to be discussed today. And then finally, we are going to share what Alliant Health Solution has as resources for you, because there are some incredible resources that I'm finding out are very, very valuable and are being used across the nursing homes, actually all across the country, because they find it very helpful. Next slide, please. So that's a lot of information. And I know that what you're hearing probably, or from the staff and, from the residents and from the family, is COVID is over. It seems like COVID is over. People are not wearing masks so much anymore. This is going to go away. So we are going to look at the data, because everything should be supported by evidence. And what we are seeing here is COVID-19 weekly death rates by age. And, as in nursing homes, typically, and assisted living facilities as well, we have a, larger set of population where we have older adults. And as you can see, that currently the death rates in the population dying from COVID are really, really concentrated in that older adult population. Our population in long-term care is, also has a lot of comorbidities. So it is especially vulnerable. So we are going to be the most vulnerable population subset, when it comes to adverse effects of COVID. So it is not over, number one. Second, secondly, it is certainly not over for nursing homes and facilities. Next slide, please. So we're going to, and I do have the control looks like, so I appreciate it. What we're going to do is we're gonna, or I may not have the control. The wastewater surveillance is, one of the ways to kind of look at what is going on in our community. I've talked about it before. I think, as the testing goes down with, this misperception of people that COVID is going away, it is very important to look at the sources of information that you are getting or sources of data. So one of the sources of data that Erica is going to talk to you about is that community transmission, based upon which your whole infection control processes, testing processes, admission processes would be resting on, what is the community transmission in your community. And however, to get the real source of information, because it depends on these sources of community transmission and community levels are really dependent on what is the testing happening. So the more people who test antigen testing and in outside places than the nursing homes or other areas where we are supposed to report positive tests, the more people do that, the less that testing comes into this equation of, what is going on in your community. So typically what we are seeing is that there is a lag or there's a mismatch, slight mismatch of what is happening in your community as far as even community transmission. So what is the source of information that you should be looking at is wastewater surveillance, because what wastewater surveillance does is it kind of has that sample collection from the local sewer system, and you basically everyone, it's like that is where you get the data of everyone, right? So that typically is the indicator that we are seeing go up faster and go down faster. So when we were in the throes of Omicron and we were wondering about, is it ever going to end? When you start seeing more of these blue dots, as you're seeing on your screen, it kind of tells you that even when you are having a very high rate of testing positive, it is about to, start to decline. Similarly, if you're seeing a lot of yellows, oranges, and reds, even if your community transmission is looking low, you got to start paying attention to that, because that's the needle that moves first. Next slide, please. And so what you're seeing in Georgia is it's a mixed bag. Some places have started showing blue, some places have, or still have those reds and oranges. And then some people are gray, some places are gray, which means they are not doing data collection at that time. But, for Georgia, it's a good tool to actually look through. And that is, you're going to find on your CDC data tracker. So if you just Google CDC data tracker, that is something that I check, almost on a weekly basis to make sure that I actually know what is going on, or what is about to happen. Now, talking about, is COVID over? Well, here is a slide that is basically, that NHSN data input, and we can see that COVID is obviously not over. What I'm hearing from our Northeast partners or Northeast colleagues is that they are still seeing, they have started seeing outbreaks after the outbreaks had gone down. So, what we see in the South is we kind of lag behind about, maybe a month and a half to 2 months, depending on how fast the variant is spreading. There is that lag that we are seeing. And so, I always talk to my Northeast colleagues and, ask them, what is going on in their communities. And what we are seeing is a little bit of a worrisome trend that they are actually starting to see outbreaks again. And that is a little bit worrisome, but we are, seeing that reflected in the data from NHSN. Next slide, please. And of course, this is the staff data. So of course, COVID doesn't typically live in the buildings. It comes from outside, and it depends on what the communities are doing in which our staff is living. And we can see that staff also has, high rates of COVID. There was a time, between January and, around the July of 2021 when it had gone down to really low levels, right? And right now what we are seeing is, some of the even though we are starting to see that decline, but right now where we sit is actually at the peak of some of the previous outbreaks. So it is not over by any standards. Next slide, please. And this is a little, this is a slide that I had to actually update. I had sent these slides out, and what I am seeing is somewhat worrisome again. And we are seeing emergence of new variants. Okay. And so I wish I could show you side by side how my slide looked before and what my slide is looking now. Within that 1 week, the pattern has changed. So what we are seeing right now is the Omicron has subvariants, right? So Omicron had subvariants. We were really worried about BA.5, and then we were worried about BA.4.6. That big, huge outbreak happened was BA.5 primarily, right? And now what we are seeing is, if you look at that top, right, that light green and that deep green, and then there is that green in the top. So that bottle green, the light green, and then that forest green. Those are the 3 new subvariants of Omicron that we had not seen. And we are starting to see them in higher proportions in the Northeast. It's about 5%, 5.7%. This BQ is the newer subvariant. Again, it is an Omicron subvariant, and that has relevance in what I'm going to talk about in a minute. But these are Omicron subvariants. The BQ 1.1, the BQ1, and the BF7 are the variants that we really need to be concerned about, because they are spreading very fast and they are taking over. You can see how they were a small thin slice before, and now they are really, really gaining that ground, which means they are highly contagious and they are overpowering the other variants. The other variant that we need to worry about is the Omicron subvariant XBB, which is the most antibody evasive SARS-CoV-2 variant that we have globally. And that is, primarily right now being reported in Hong Kong, Singapore area. And that is something that we're going to have to keep an eye out on. BA.2.75.2 and BF7 are the 2 variants that we have seen in UK, and now they have jumped over to here, and we are seeing those variants here. Bottom line is, these are all Omicron subvariants, and they are spreading. So we have to keep an eye out on what is going on the ground, because this is our maybe 5th go round or 6th with these big surges of infection that happen. We don't want to be caught without without protection. Our patients don't need to be caught without protection. Next slide, please. All right, which brings me to the following. The new up-to-date definitions from NHSN. And I completely agree with them because of what we have just discussed. So as we know, that our new booster, which is the updated booster, is required for up-to-date status on vaccine. And that went into effect September 26th. And essentially, basically, when are you considered up to date with COVID-19? This is something that NHSN is following, CMS is looking at, CDC is looking at, and the most importantly, I, as a medical director, am looking at in my facility because it determines how well protected my patients are. Here is the thing. The previous boosters that we were giving were boosters against wild type. Wild type is the first COVID-19 that affected us. That is 2.5 years back. And we have to give it over and over and over again because it has been so far back and the virus has changed the way that it looks like and acts like, and we are here. Now, the updated booster, which is a bivalent booster, has protection against the wild type, which was 2.5 years back, and has protection against the Omicron BA.4/5. So what it does is it has protection against the whole range of the variants that have come in: Alpha, Delta, Beta, Omicron, and now what we are dealing with in the foreseeable future is a bunch of new Omicron variants. And that is why it is so important for our residents and our staff to take the updated bivalent booster. When I say updated, that means bivalent. As you can see on the slide, it's called updated bivalent booster, and they can be used interchangeably. But that bivalent booster is going to provide you protection, very good protection against Omicron. And that's what we are going to deal with in the next possibly year or year and a half or two. So we shall see. But all the new variants that are coming in right now are the Omicron subvariant. And this new vaccine, the bivalent vaccine, has protection against Omicron. The old vaccine, what we have seen from that one, which was only against wild type, is the immunity or the protection started waning in about 3 months. And that's why they told us that, oh, if you're 3 months away from your last booster, you need to get another booster. Because the new updated vaccination, updated bivalent booster has such a good immunity against both sides of the spectrum, it is only given once a year and you don't have to repeat it over and over. So that is the reason why they were asking for doing every 3 months on the old vaccine, and they are saying only this will last you for a year for the new vaccine. So that is something that we need to communicate to our staff and to our residents and to their families when they say, what, just another vaccine, one more vaccine, I don't want to take it. I think that education needs to go out to our families and staff that this is the vaccine that you need to take because this is going to be one and done for the year. So going back to the definition, if you have received an updated bivalent booster, you are up to date for 1 year and you don't have to take any further vaccines. Or if you just had your booster, the monovalent booster or the old booster, the old vaccine, and you're within 2 months of that, you're still considered up to date. At 2 months from that last vaccine, monovalent vaccine, you will get out of the status of up to date and you will have to get the updated booster. If you are just now getting your primary series, if you are within that, interval between first and second, or you are past that second and still within the 2 months of your primary series, you are still considered up to date. However, at that 2 months from that second shot, you are going to be considered out of date. So you will have to get that updated booster. Next slide, please. All right, so this is basically the definition of up to date that CDC has presented to us or has for us. And these are different scenarios. So people who are age 18 and older who have previously received Johnson & Johnson, they would have received their primary. They need to get a bivalent booster and they will be up to date. people who got the Moderna, Novavax, or Pfizer vaccine, if you're 2 months out from those, you get one booster, updated booster, and you're up to date. Now, the new thing that just got dropped is on 19th, 2 days ago. CDC basically came out, FDA came out and approved the Novavax for a booster only for people who have either severe reaction to mRNA vaccines and can no longer take mRNA vaccines, or who are unwilling to take the mRNA vaccine. As we remember, if you were there in the last talk that I did about Novavax, Novavax is made exactly like the flu vaccine in moth cell factories. It does not have a mRNA. So if you have taken a flu shot before, you should be able to take this shot because it's made exactly the same way. So if you were not going to take the mRNA vaccine because of concerns, if you had a serious allergic reaction to mRNA vaccine, you would be eligible for Novavax. It's still recommended that try to get the mRNA vaccine 2 months from the last shot. Novavax is only for that small subset of people who either cannot take or are unwilling to take the mRNA vaccine. This vaccine, if people are going to take it as a booster, needs to be taken 6 months from the last shot. It kind of creates that level of complexity. This is still new. This only came 2 days ago, this approval. So CDC is still updating these guidances as we speak. But I did want to bring that up to your attention, that option is available now for people who are either unable to or unwilling to take the mRNA vaccine. This is the implication of that. How do I put that in practice in my nursing home? If my staff has taken the flu vaccine in the past, then I am offering, and they are not willing or unable or have, religious exemptions from the mRNA vaccine for whatever reason and have taken the flu shot before, I am approaching them with the Novavax so that they are protected against the COVID during the surges that we are likely to see. Next slide, please. All right, so this is, again, for people who are immunocompromised, and I'm not going to make it super complicated, but basically immune-compromised people need 3 doses of primary mRNA, primary series mRNA vaccines, continue to have 2 doses of Novavax. For Johnson & Johnson, they get the 1 Johnson & Johnson and an additional mRNA vaccine before they become eligible for booster. So just wanted to let you know that as well. All right, next slide, please. And this is the definition, very clear definition of who is immunocompromised. So the most important thing here to note is that high-dose corticosteroids, 20 milligrams or more of prednisone, is when administered for more than 2 weeks is considered immunocompromised. Those are the people that you're likely to see in higher numbers in long-term care facilities. So since this is being recorded and this is available to you, you can certainly look over this definition and make sure that your consultant pharmacists know to basically look for the immunocompromised and get them that extra shot. Next slide, please. All right. The biggest issue with boosters is that the labeling. So just to reiterate, old monovalent vaccine should not be used as booster anymore. Should not be used as booster anymore. J&J cannot be used as booster anymore. In a very small subset, Novavax can be used as a booster as of 2 days ago. So we have to remember this. Here, the main thing is that reading the label is going to be incredibly important. Don't mix the bottles of old monovalent vaccine and the new updated boosters. Otherwise, this is going to cause massive confusion. It clearly states bivalent. What we want to look for in the bottle every time you give the booster shot is that word bivalent. If you're using the Moderna, the cap is a different color. It's a blue color. It's a new color. The problem with Pfizer is the cap is the same color. It's the gray cap and the same color of the label as well. What you want to look for is clearly bivalent word in that. Next slide, please. All right, so do they work? Yes, they do. So if you look at the Omicron, which is what we are dealing with for the next foreseeable future, the level of immunity or antibodies that the new vaccine generated against Omicron compared to the old vaccine in all participants. So they said, well, does it work for people who didn't have COVID? Does it work for people who had COVID? Okay, so all of them, when they all were combined, it seems like the protection that it provides is double the protection against Omicron compared to the old vaccine. With no prior infections, the protection that is being provided is almost double the protection of the previous dose of Omicron, the previous dose of the monovalent vaccine. And even if you did have illness, it is going to provide you that double protection, even more protection against any future infection. But definitely, and you may get infected, as we know, if this infection surges in the community, your innate immunity, no matter how high it is, will get overwhelmed and you may get that infection. What you will not get, or what you have significant benefit on, is serious disease, hospitalization, and death, similar to the flu vaccine and similar to many other vaccines that we take. So we need to remember that. So the protection is almost double from the current data that we are seeing. Next slide, please. So it works very well against booster. Do we have more side effects? And if we see, the top is just the monovalent vaccine, the bottom line is the new vaccine. And as you can see, really there is no significant difference in the side effects, whether local or systemic, in taking the new booster. And why is that? Because Moderna, for example, has 50 micrograms. What they do is, instead of doing 50 of old type and 50 of new type, they do 25 of old type and 25 of new type. With that, they're still seeing an amazing higher level of protection against all across the board, and a broader protection and no increase in side effects. So the side effects are not significantly different. Next slide, please. And this is a co-administration chart. So basically they said, well, what about, this is flu season. What about if we give the flu vaccine and the new updated booster together? What they found out is the local side effects, whether you gave the flu vaccine alone, high-dose flu vaccine, they compared people with high-dose flu vaccine only, high-dose flu vaccine and updated booster, and updated booster only. And what they saw is the local effects of high-dose flu vaccine or the booster do not change, whether they are given together with at the same time, or whether they are given alone. So essentially making a case for co-administration. So if you're giving high-dose flu vaccine, you want to use two different arms. I had regular dose flu vaccine and I had my updated booster. I took them both in the same arm, and those effects are not significantly higher than if you took the vaccine alone. So in our nursing home, almost everyone has had co-administration, high-dose flu vaccine and an updated COVID booster. Next slide, please. All right, and this is why we need to hurry up and give our flu vaccine and ask our staff to get the flu vaccine, because as you can see, this is available again on CDC, and I would really recommend that everyone looks at your flu data periodically, hopefully on a weekly basis. And as you can see, Georgia is red. So there are a lot of flu cases in children, in adults, and we are going to start to see really, really, crazy flu season that we are anticipating, because the herd immunity, because of everyone wearing a mask, has gone down because we have not had the flu in the last 2 years. So that constant activity of flu keeps our immunity revved up. We have not seen that for the last 2 years. And now guess what is happening? Masks are coming off, and we are anticipating more respiratory viral illness. So flu shots need to be given. Next slide, please. All right. 2 out of 3 adults have said that they want the vaccine. Side effects are comparable. Flu vaccine rates are going up from people who are doing it. They are saying, oh, Mrs. So-and-so, who had refused flu all her time, has taken the flu shot this time as well. So we are seeing that increase in rates of flu. You use less nursing home resources if you're giving it all at the same time. And think about this. If you gave your flu shot and then turn around and said, hey, can I give you the bivalent vaccine? What are people going to say? They're like, not one more shot. So you are going to lose that opportunity because people are getting fatigued by getting vaccines. Next slide, please. All right. Vaccines are very, very effective against hospitalization. As you can see, the bottom line is the people who are unvaccinated, well, who have had only the primary series here at the end of the series. This is the only primary series. So people who say, oh, I got my primary series, I should be good to go. No, you're not. Look at the green, which is basically boosted, folks. It really helps. Sorry, the primary series is the blue one. I can't, the green ones are the people who are unvaccinated. What we are seeing is the unvaccinated people going at a higher rate, and primary series at a slightly higher rate. What we are seeing with boosters in the newer studies is that they are almost close to zero. So people who are getting admitted to the hospital are literally the people who are either unvaccinated or who have had primary series way back when, and no other vaccines, or they are seriously immunocompromised. Next slide, please. And we are seeing the same with deaths as well. The black line is the unvaccinated, and the blue line is the people who are boosted. So what we are seeing is the risk of testing positive COVID is 2.5 times higher with no vaccine compared to people who are vaccinated and boosted. And this is the data from July end. And then 7 times higher chance of dying. So definitely people who are still getting admitted in the hospital who are still dying are the people who are primarily unvaccinated or are not up-to-date vaccinated and have immunocompromised status. Next slide, please. And so we need to remember that we need to kind of go to a risk-based model, and up-to-date vaccination is one big pillar of that. The 2 other big pillars, as equally important, are PPE and infection control and testing. So with that, I will turn it over to Erica. Thank you, Erica.
Thank you so much, Dr. Gar, and good afternoon, everyone. I will be presenting CDC guidance updates and their relevance to your IPC practices that you're currently doing. And Dr. Gar brought up some excellent points that I'll also reiterate as I'm talking about the CDC IP guidance updates. Next slide. So here are the guidance documents that I'll go through primarily in this presentation. I'll focus a lot on the first one, which is the interim IPC recommendations for healthcare personnel. And the subsequent two guidance documents are a tie into the IPC recommendations, and they focus on managing healthcare personnel after an exposure, and then also updates to considerations for when you should, when you experience personnel staffing shortages. So we'll run through those later in the presentation. So in general, here are the key things about infection control, prevention and control that have been updated in the new interim IPC guidance for healthcare personnel. So the things are listed here, and they are related to source control, the universal use of personal protective equipment or PPE, COVID-19 screening and testing, transmission-based precautions for asymptomatic residents, and then they actually combined the nursing home guidance and rolled a nursing home guidance into this IPC document. And this is what we talk about when we say setting specific guidance. And I'll talk more about that in the presentation. It's important to note that all of these updates were made to reflect the high levels of both vaccine and infection-induced immunity, and also the availability of effective treatments and prevention tools. And so as you're thinking about, you know, where am I now? Where is our facility now moving into this, pivoting into this kind of endemic COVID response? We want you to think about this guidance as a framework for your facility to guide their implementation of their IPC practices based on the risk in their community and then within their facility. And we'll talk again more about that a little later. Next slide. So this is the slide I just referred to. We're talking about source control, universal PPE, COVID-19 screening and testing, and transmission-based precautions, and then the setting-specific guidance that we'll discuss. Next slide, please. So here are the major updates that are all throughout the guidance. They're listed here. First, vaccination status is no longer used to inform source control, screening, testing, or post-exposure recommendations. Source control recommendations are based on transmission levels, and we'll talk about a little bit about that. The universal use of PPE are also based on transmission levels, and that's in the next slide. Asymptomatic residents no longer require empiric use of transmission-based precautions following close contact with someone who has a known SARS-CoV-2 infection, so after an exposure. And when we say empiric use, we're specifically talking about the broad application of transmission-based precautions as a form of protecting the individual's residents and preventing the potential transmission of COVID as you're waiting for the test result to come back. Also, there have been updates related to the frequency of testing. So it's recommended that there's going to be an increased testing frequency in an effort to detect potential variants with shorter incubation periods. And those variants are what Dr. Gar already mentioned are pretty much here, and we need to be on the lookout for. Also, increasing the testing frequency addresses the risk for false negative antigen tests, especially in those who are asymptomatic. And then again, the major component of this IP guidance now is that it's applicable to nursing homes. Prior to this update, the nursing home specialty had their own set of IP recommendations. But as of right now, that has been archived, and now all the nursing homes need to follow this general IPC guidance and updates. And also, in addition to that, there were some updated recommendations for screening testing for nursing home admissions. Next slide, please. Thank you. So let's talk about these transmission levels because, I was like, how are we supposed to use these? And interestingly enough, CDC has two types of metrics that will help inform infection prevention risk. One for the healthcare facilities and systems, and then the other for non-healthcare facilities and just those who are interested in managing their own individual and community level risk. And again, this is not associated with the nursing healthcare system. So when we talk about transmission levels, this is specific for healthcare facilities, and this is what they should be looking at to inform their IPC recommendations. And this metric uses two indicators. One is the number of new cases per 100,000 people in the last 7 days, and then also the percentage of positive diagnostic screening nucleic acid amplification tests, or NAT tests, during the last 7 days. And NAT tests are a specific type of viral diagnostic tests, usually your PCR tests, that are very sensitive for picking up SARS-CoV-2 virus and, of course, diagnosing a COVID-19 infection. So transmission levels is what healthcare facilities should be using. In contrast to that, the COVID-19 community levels use three indicators. And one, of course, the new number of cases, but also they look at the number of new hospital admissions in the last 7 days that are related to COVID, as well as the percent of inpatient beds occupied by those with COVID, confirmed COVID. So if you look at the difference, just look at the map, it shows you complete difference in terms of the transmission, but also just the risk. So if you're looking at the graphic to the bottom left of the United States, you'll see that majority of the country has a relatively high risk of or high transmission levels of COVID, because red indicates high, and I believe orange is substantial, yellow is moderate, and blue is low. So just again, look, this is what you need to be looking at. And if you look at this presentation, you're going through and review it, the links are actually embedded in the slide here. Next slide, please. So in terms of what we just discussed about the transmission levels, again, transmission levels is what you should be looking at for your healthcare facility to inform your IPC decisions. The transmission levels are now updated on a weekly basis. And so it'll be best practice would be to go to that website probably on a Thursday or Friday, because they're starting to be updated weekly as of this Thursday. So I believe next Thursday is when the next update might come out, next Thursday or Friday. But nonetheless, be sure to check them weekly so that way they can inform your strategy on a weekly basis and moving forward. And then again, the COVID-19 community levels is only for non-healthcare settings. So that includes assisted living facilities, group homes, retirement communities, and congregate settings. And it just helps people realize kind of what's going on with in their community related to basically the healthcare infrastructure in the event they may get sick and may need to go to the hospital. And again, we don't want any type of risk there to continue to increase. And so this is specifically for those individuals who want to take to consider their own risk at their community levels. Next slide, please. So jumping into these specific updates. So let's talk about source control. So when transmission levels are high, source control is recommended for everyone in areas where they could encounter patients. So, of course, that is wearing a face mask or a facial covering to make sure that any type of respiratory secretions or any type of potential exposure to the virus is contained. And this is when both staff and visitors and everyone that enters in the areas that encounter patients should be wearing source control when transmission levels are high. Healthcare personnel could choose not to wear source control in areas that are restricted from patient access if community levels aren't so high, and also if they meet the criteria below, which I'm about to highlight. So when transmission levels are not high, source control is recommended for individuals who have the following. They have a suspected or confirmed respiratory infection. They've had close contact with someone with a COVID-19 illness. So basically they've had an exposure and they need to wear source control for the next 10 days after that contact. They reside or work in an area of a facility that's experiencing a current COVID-19 outbreak, or they have recommendations from their local public health authorities to go ahead and implement source control. It is important to know, especially in the context of when transmission levels are not high and source control is not recommended necessarily for everyone, that even those healthcare personnel or individuals who want to wear source control, they should be encouraged to wear source control, even if it's not necessarily required by the facility. Next slide, please. So when it comes to universal PPE use, when transmission levels are high, you should consider implementing the broad use of respirators and eye protection for healthcare personnel during patient encounters. And the NIOSH approved particulate respirators, like with N95 filters or higher, should be used for aerosol generating procedures, any type of surgical procedures that may pose a higher risk if the resident has a SARS-CoV-2 infection, or if there's any type of manipulation or care related to the nose, throat, oral pharynx, or the respiratory tract. Also, if the patient is unable to use source control, if the patient is unable to use source control, if the area is poorly ventilated, if there are specific areas or units on your facility that are also at higher risk of SARS-CoV-2 transmission. And when we specifically talk about eye protection under this circumstance with the universal PPE, we're talking about goggles or a face shield that covers the front and side of the face that should be used during all patient care encounters. And again, throughout this presentation, you'll see hyperlinks that you can go back to refer to, as well as the actual guidance at the bottom of each page, each slide. Please, next slide, please. In terms of testing updates, we're specifically talking about testing someone when they've had a known exposure. So when you have an asymptomatic resident who's had a close contact with someone with the SARS-CoV-2 infection, so they've had an exposure, the recommendation now is that you should perform a series of 3 viral tests to look for SARS-CoV-2 infection. So testing is now recommended immediately, but not before 24 hours after the exposure. And then if that test is negative, then they should be tested again 48 hours later. And then if that second test is negative, they should be tested again 48 hours after, for a total of 3 tests. So if you're looking at testing and like the timeline for it, testing should occur on day 1, where the day of exposure is day 0. Day 3, and then day 5. Other considerations when it comes to testing is that it's generally not recommended for asymptomatic individuals who've already recovered from a SARS-CoV-2 infection in the last 30 days to be tested. That's just something that it probably is not going to be helpful or informative, potentially, because they could still might even be still testing positive from their initial infection. However, for those individuals who, again, have had an exposure and have already, asymptomatic people who've had an exposure, but now are part of this, serial testing, and they've recovered within 31 days to 90 days, so about up to 3 months, they could go ahead and be tested using an antigen test instead of a NAT test, because again, the NAT test will be highly sensitive, and also the NAT test may again remain positive even after they've recovered from their initial infection, and even if they test positive, they may not necessarily be infectious. So just again, asymptomatic individuals should be tested on 1. Asymptomatic individuals following an exposure, that's the caveat here, should be tested on day 1, day 3, and day 5, and special consideration should be applied and considered for those individuals who've recently recovered from infections. Next slide, please. So in looking at the transmission-based precautions updates, again, this specifically applies to asymptomatic residents who've had an exposure to SARS-CoV-2. And prior to this guidance, there was the empiric use or the application of using transmission-based precautions as a way to make sure that you're not spreading transmission prior to that test result coming back. However, according to this new update, Asymptomatic residents do not require empiric use of transmission-based precautions while being evaluated for SARS-CoV-2 following an exposure. However, these residents should still wear source control, and they should also be tested, as I mentioned before in the previous slide. Examples, though, of when you could potentially use empiric transmission-based precautions with these asymptomatic residents who've had an exposure is if they're unable to be tested or wear source control as recommended for 10 days following their exposure, if they're moderately to severely immunocompromised, if they're residing in a unit where there are other residents who are moderately to severely immunocompromised, and also if they're residing on a unit where you're experiencing an ongoing COVID transmission. Empiric use of transmission-based precautions is unnecessary for residents or for admissions or residents who leave the facility for less than 24 hours and do not meet the above criteria. Next slide, please. In terms of screening testing updates, so this is just kind of like the active screening and looking for COVID-19 in your facility. This refers to that process. So screening testing of asymptomatic healthcare personnel is now at the discretion of the healthcare facility. They do note that screening testing for identifying asymptomatic infection might actually be useful in some situations, and it could help inform certain IPC measures and interventions of like room assignments and cohorting and the use of PPE when you're engaging in, for example, a high-risk procedure, or you have a healthcare provider who is caring for patients who are moderately to severely immunocompromised. If you're implementing a screening testing program, testing decisions should not be based on the vaccination status of the individual being screened. And again, the screening testing is recommended here, similar to the testing, so the serial testing that we mentioned above in the previous slide. Screening upon admission is recommended for facilities in counties where transmission levels are high. So again, if you live in an area that has high transmission based on those transmission levels and that metric that CDC puts out weekly, if you're living in that area and you're getting a new admission, the new admission should be screened if your transmission levels are high. Admission testing at lower levels of transmission is at the discretion of the facility. So again, if you live in an area where it has low transmission levels based on that CDC metric, then admission testing is based on your discretion. Next slide, please. And this is where I'll highlight the setting-specific updates, and I'll start with this bottom bullet here. So long-term care facilities, which are excluding nursing homes, whose staff provide non-skilled personal care, so this could be an assisted living, a retirement facility, or any type of group home, and they provide non-skilled care that would be similar to family members providing care. They should follow the community prevention strategies outlined in CDC's guidance based on the COVID-19 community levels. And if you recall the slide that I showed earlier, comparing the transmission levels versus the COVID-19 community levels, these group of people who will provide no skilled personal care should be following the COVID-19 community levels, even if they live in a residential group home or have more than one person or more than one resident in their facility. However, if there are healthcare providers who are visiting those facilities who are there with the intent to provide healthcare related services like physical therapy, wound care, any type of IV injections, or even catheter care, especially if it's provided by a home health agency, they should be following the healthcare IPC recommendations that are outlined in the interim infection prevention and control recommendations for healthcare professionals. Next slide, please. So, sorry, could you go one more slide? See, go up one slide. Oh, sorry, go back 2 slides, I think. Okay, yeah, let's see. Yeah, yes, go down 1 slide. I'm sorry for the confusion here on my end. Okay, let's move to slide 36. I lost my track here. Thank you for your patience. Okay, so the interim guidance for managing healthcare personnel exposures has also been updated to reflect that asymptomatic healthcare providers who are at higher risk of exposure, who've had high risk exposure, do not require work restriction regardless of their vaccination status. If they do not test symptoms or test positive for COVID, SARS-CoV-2, so that's just an important to remember. They should be you should be considering work restrictions if the healthcare provider is unable to test or wear source control as recommended for 10 days following their exposure. If the healthcare worker is moderately to severely immunocompromised, if the healthcare provider also cares for people or residents on a unit that they're moderately or severely immunocompromised, and then also if the the unit is experiencing some type of ongoing SARS-CoV-2 transmission. Also, when you're testing your asymptomatic healthcare worker who's had an exposure, the testing frequency is very similar to the testing residents following exposure, where you would test 3 times on 3 different days. So that's day 1, day 3, and day 5. And then also the specific time to test in consideration, the specific consideration related to asymptomatic testing and people who've recovered from a recent SARS-CoV-2 infection is also applicable here, similar to the residents. Next slide, please. 37. And then lastly, the strategies to mitigate healthcare personnel shortages guidance has also been updated to reflect that asymptomatic healthcare providers with higher risk exposures do not require work restrictions, and that's regardless of their vaccination status. So just continue to remember that as you're moving forward and planning ahead with your occupational health evaluations and risk assessments. Next slide, please. So in line with CDC's updates, the Centers for Medicare and Medicaid Services also updated their guidance, and this particular guidance reflects the testing recommendations. And the link for the guidance here from CMS is embedded in the slide, but also would like to call your attention to Table 1 in the guidance, which provides an excellent summary of when to test, the testing triggers, so when to test, who to test in terms of both staff and residents. So please take a look at that guidance. It's very helpful and informative. Next slide, please. Also, CMS updated their nursing home visitation guidance, and this reflects the current CDC guidance. And I just want to iterate here that facilities should provide guidance about recommended actions for visitors who've had a positive viral test for COVID-19. If they've had any symptoms or had close contact with someone with COVID-19, they should make sure that they pretty much defer any type of non-urgent in-person visitation. If they've had close contact with someone with COVID-19, they should at least defer for 10 days following that contact. In addition to that, it's very important that the facility continues to recommend hand hygiene and have those materials and resources, supplies available, as well as a face covering or mask covering both the mouth and nose in accordance with the CDC guidance, meaning the transmission levels in your community. So that should inform your guidance for visitors in terms of if they should be wearing source control. Next slide. So that concludes the main content in my presentation. I come from an excellent team with a wealth of expertise here at Alliant Health Solutions, and we are available to assist you as you're working through these update changes, whether that's related to the vaccine boosters or IPC. And we're just here and available, so feel free to reach out to us directly. I would like to reiterate that, as Dr. Gar mentioned, we're coming into the cold and flu season, so it's very, very important as we're pivoting our IPC recommendations and application as it relates to COVID that we not forget just general IPC. in terms of maintaining our vigilance and making sure that we're continuing to do things and practice certain IPC measures like respiratory etiquette, hand hygiene, cleaning and disinfection, and of course, the application of source control and then COVID-19 precautions as needed. So just remain vigilant, excuse me, and also continue to reach out to us if you need any assistance with your IP initiatives. And with that, I think we have just a minute or two for questions.
Erica, at this time, we do not have any questions, and in just a moment, there will be a poll popping in for your answers. If you will please take a moment to answer those questions, that helps us to do these presentations and really get you what you want to be hearing about. But at this time, we do not have any questions in chat or the Q&A session.
Okay, thank you so much, Mel. Next slide, please. Also, in addition to reaching out to Alliant Health, we have excellent resources and a wealth of expertise with our Georgia Department of Public Health and their healthcare associated infection team. Their contact information is listed here on this slide. Next slide, please. Also, please save the date for the next upcoming office hours on November 18th at 11 a.m. and also for our assisted living facilities and personal care homes on November 18th at 1 p.m. Next slide, please. Thanks again to our partners at Georgia Department of Public Health and also the University of Georgia, because again, without their participation and support, this would not be possible. So thank you all so very much. And thank you for our attendees for your time and also for the work that you all do on a daily basis to keep your residents safe. And please continue to follow us and reach out to us on our social media accounts and handles that are listed here. Thank you so much. And I think that concludes our presentation for this morning.
It does, Erica, and we don't have any questions in chat or in the Q&A box. To you and Dr. Gar, we thank you very much for your presentations today, but most especially for everyone attending. We thank you for your attendance and wish you a great weekend.
Thank you.